Allaitement pour tous brings you Latch, Identifying the Causes When It Isn't Working, by Charlotte Young from the Allaitement pour tous International Headquarters. All rights reserved. When the latch techniques shown in Latch Illustrated are not working and the baby is not able to efficiently and easily remove milk from the breasts, it's very important for the mother's and baby's health to find out why. Sometimes the cause of an impossible or difficult latch is simply a question of the wrong approach, an ill-adapted breastfeeding position, or inappropriate breastfeeding management, or that the baby is getting supplements not from an at-breast supplement system that protects the breastfeeding technique, enabling the mother to give supplements at the breast, but from artificial nipples that tend to sabotage the breastfeeding technique. Or perhaps lactation got a late start and the breasts were not emptied frequently, starting from within the first hour after birth. If all those mother-baby separation and breastfeeding traps have been avoided, and despite proper breastfeeding management, position and frequency of feeding, breastfeeding still hurts and the baby cannot latch properly, the cause can almost always be found in the baby's sucking technique. The reasons for oral dysfunction can be multiple factors, and there are always not only techniques and approaches to surmount the problem, but also tension-releasing mobility therapy to enable normal oral function and maxillofacial development. Recent studies show us that the milk removal process must start within the first hour after birth to ensure an abundant and easy milk supply. If that window was not respected and an abundant milk supply has been jeopardized, catching up, increasing milk production is never too late with the right techniques. See Dr. Jane Morton's hands-on pumping videos for study-based demonstrations. To get more information on ensuring an abundant milk supply at birth, see Dr. Jane Morton's website, Droplet. After obvious traps such as sabotage by artificial nipples, a late start, spacing out feeding, separating mother and baby, and ill-adapted position, what about breastfeeding management, structural tension, tongue or lip frenum? What else is there to check? What about enough time at the breast? Human milk digests in 20 to 40 minutes, and babies' stomachs are so small they need to feed frequently. Is the baby getting enough time at the breast to gain weight, become strong, and to be able to completely drain the breasts at night as well as the day? Or does the baby fall asleep at the breast? Or, to the contrary, does the baby breastfeed all day yet still not gain weight? Before identifying the cause of oral dysfunction, firstly, basic breastfeeding management should be checked by a trained specialist, such as any La Leche League leader or a lactation consultant certified IBCLC. All mothers and future mothers are welcome to La Leche League meetings all over the world at no cost, but there will be a fee for an IBCLC individual consultation in private practice. Once basic breastfeeding management, position, and latch have been checked, the next point to address is feeding function and structural tension. Structural tension is hidden to the untrained eye, obviously, but there are some clear signs that anyone can observe if they know what to look for. When the baby is at the breast, do the upper and lower lips not stay rolled back despite manual help? Is it impossible to maintain the space between the nose and the breast because the baby readjusts the angle of his head so that his chin is dropped closer to his chest? When a baby does that, of course it pulls the nipple to the front of his mouth and rubs against the front hard part of his palate. Have you observed that once the baby is latched, he can only nipple feed with his jaw only partially open? Or that the only comfortable opening a baby can manage is really not open at all? Can the baby extend his tongue under the breast only after partially closing his mouth, as seen here? Have you observed that when the baby opens his mouth wide, the tongue retracts? Compare a retracted tongue to this super tongue extension with a wide open mouth. It's ideal for efficient milk removal. To learn how to observe the dynamics of tongue and jaw mobility in normal infant feeding ability, there are a few basic points to check. Are both breasts being completely drained at every feed, or do the breasts remain partially drained, then get hard or engorged? Does the mother suffer from frequent cracked or sore nipples, clogged ducts, or repeated engorgements? Are nipple shields necessary to avoid painful breastfeeding? Is the baby more efficient on one side than the other? Does the baby drink only while the milk is being ejected, the first few minutes of a feed, then stop? Or become ineffective at getting the milk out? Or fall asleep at the breast before the breast has been completely emptied, or before the baby has obtained enough milk to really be fed? On condition the position, breastfeeding management and frequency are appropriate, all of the aforementioned are clear indications of structural tension. If structural tension is hindering tongue mobility now, unless treated, breastfeeding, later chewing, and any normal use of the tongue will always require an enormous effort. When structural tension is not released, the developing, growing body will twist and turn to accommodate the constant tension. Considering the percentage of babies suffering from what is commonly called colic, an overactive nausea reflex, digestion problems, reflux, sleep problems, sleep apnea, food allergies, hyperactivity, learning problems, reading problems, and elocution trouble, without ever having the question of structural tension addressed, and instead are put on medication, the 80% of the population with structural tension is hardly surprising. All of the following images reflect some form of structural tension. Please note, in these images, when the babies are in a resting position, the lower lip is tucked under the upper lip. Here, there is evidence of tension that is definitely not retrognathia. The tension in this baby's mouth is so restrictive the tongue cannot stay comfortably in the palate while resting, so the baby can only breathe through his mouth. According to maxillofacial experts and well-educated dentists, inability to breathe through the nose is a clear sign of dysfunction. Here, the tongue is always visible in the resting position. Notice the fallow below the lower lip. Something is exerting a lot of tension on the place where the future teeth are housed. Asymmetry in the eyes is very common after birth. The cause is most commonly due to structural tension. Babies spending a lot of time on their backs are at risk of cranial asymmetry. The biological norm for human babies is to be carried in the day, vertically or horizontally. The biologically normal sleeping position is on the side, next to their mothers, changing sides several times in the night. In those conditions, the rate of plagiocephaly is much lower than in societies that don't carry or sleep with their infants. Helmets, special head cushions, and other such support tools affect only the aesthetical aspect of asymmetry. When the cervical vertebrae are the cause of structural tension, the direct release of tension by the gentle touch in the right places by trained chiropractic hands will be able to accurately identify and address cervical misalignment that causes so much structural tension. Be aware that pediatric chiropractic work is completely different from adult chiropractic work. Pediatric chiropractic work is a question of mobilizing rather than manipulating. The long-term impact of leaving structural tension untreated can sometimes be physically visible by even an untrained eye, but sometimes is only evident in unexplained headaches, migraines, digestion problems, tension in the shoulders, the neck, the thorax, by adult reflux, and can even end up in scoliosis. Whatever the cause, aesthetic treatment does not address the cause, and it's an unfair approach to the person suffering from the tension. Many types of structural tension can affect a person for life, whether it's caused or exacerbated by tight oral tissue or not. Since the act of being born is a violent experience for the baby, It is very important to have structural tension checked by a pediatric chiropractor. Chiropractic training does not vary from school to school or even from country to country. It is a doctorate diploma in countries like Germany. Chiropractors are legally apt and trained to check and mobilize all structures and more specifically the spine and cervical vertebrae. In some countries, like France, chiropractors are the only practitioners legally apt to mobilize cervical vertebrae. Regardless of the type of frenum, tongue or lip, whether it's an obvious type 1, type 2 anterior frenum, or the not obvious type 3 and type 4 posterior frenum, if it's tight enough, it will create mobility restriction in the tongue, jaw, and related structures. The tissue under the tongue and under the upper lip are membranes that didn't degenerate in the fetal development stage. If the remaining membrane is tight enough to create mobility restriction, that restriction can create oral dysfunction, meaning, among other things, feeding function, but can also prevent normal closed-mouth breathing and can result in sleep apnea, jaw clenching, bruxism, and malocclusion. For the long-term impact on health living with oral dysfunction, see the research by Dr. Brian Palmer, DDS, and more recently, work by Dr. Alison Hazelbecker, Dr. Martin Kaplan of Boston, and in Melbourne, Dr. Dan Hansen's work. If the frenum under the tongue and or lip are not obviously restrictive, it is impossible to know if the frenum affects oral function or not without first ensuring that structural tension has been released. So identifying if a posterior frenum is affecting feeding function or not, after having structural tension released, there are some obvious clues anyone can identify. To learn the basics of tongue tie or ankylodlosie, subscribe to this channel to get a notification for the upcoming tongue tie assessment by Allaitement pour tous on this channel. Please be aware, not breastfeeding is big business. While pluridisciplinary support is the best way to find out what's making breastfeeding difficult, be aware that in many countries, healthcare professionals do not receive any training in breastfeeding. In France, at this time, the only breastfeeding training offered to graduating pediatricians in the 7 years of medical training in pediatrics is an obligatory module on infant feeding offered by Nestlé. The Nestlé module is imposed on future pediatric graduates by contract and state approved. Can you spot a problem? The current up-to-date research on breastfeeding, structural tension, and on tongue tie or ankylodlosie that includes research on posterior frenum does not at this time exist in medical textbooks. Research over the last 15 years on posterior tongue tie is available in books and papers published, some of which are available to the public online. Although chiropractic diplomas are doctorates in Germany, in France the chiropractic diploma is labeled by the medical profession as unconventional pseudoscience. According to Keith Hansen from the World Bank, just in sheer, raw, bottom-line economic terms, breastfeeding may be the single most effective investment a country can make in any sector for any reason. Do you see conflict of interest in economic policies? The art of breastfeeding is something that is learned both from practice but also from science-proven results. Expertise in the art is not common and rarely taught, just as one would not expect any particular knowledge of a city from a non-native or great level of fluency from a non-native speaker. It is unreasonable to expect any in-depth knowledge or training in topics such as breastfeeding, structural tension, restrictive oral tissue, maxillofacial development, or tongue and jaw mobility from most healthcare professionals. Check in your country who is training healthcare professionals in breastfeeding and what infant feeding practices are promoted. What conflict of interest is present in infant feeding training? A WHO International Code on for-profit infant feeding marketing limits has been signed by almost every country on the planet. If you see violations of the code, take a photo and report them to the International Baby Food Action Network or the World Alliance for Breastfeeding Action, and share them on your social network. Help contribute to creating awareness of the importance of non-conflict of interest and of IBCLC certified training in breastfeeding.